Hello everyone, welcome back. This is Professor Harkirat Bal, and we'll continue with part 2 of our lecture series on substance-related and addictive disorders. Okay, remember the slide from part 1? Just a quick recap. We have divided these agents into two broad categories, if you will. The first one is classes of substance related disorders, and then number 2 is a non-substance. Under substance we have 10 items arranged in alphabetical order, and under non-substance we have just one, which is a gambling disorder, and then very briefly at the end we'll talk some other items that they might consider next time. But in part 2 in this series, I'm going to start with number 1, which is alcohol, and we'll finish at number 5 because it's going to be a long lecture, I know that. And when I come back in part 3, we'll start with number 6, and then we'll finish the rest of these items. Also, please understand, I'm not going to spend same amount of time for each of these agents. I will cover all of them though, but most of the information is going to overlap. I know for sure that I'm going to spend a lot of time on alcohol. Yeah, well, simply because it's one of the most commonly used agent, and that's number 1 on our list anyways, so I'll set the stage. But I'm gonna touch other items very briefly, like maybe a few minutes on caffeine, cannabis, and so forth. Very small talk on number 4 and 5. I will spend again a lot of time on number 6 and then rest very briefly. Okay, so they're not gonna get equal amount of time, but you will get all the important information that you really need, though, that I promise. Okay. All right, we'll start with the number 1, alcohol use disorder. So pay attention to the terminology. Remember, I'm not saying abuse, I'm not saying addiction, right? So alcohol use disorder. And for every disorder, you'll see a similar type of a slide where you'll see the number and the name. Remember that 10 altogether. So the first one is alcohol. Then you'll see a very brief description of that, and then we'll after that we'll dive into that disorder. Okay, so with alcohol use, you have a problematic pattern of alcohol use leading to clinically significant impairment or distress occurring within a 12-month period. So just keep that in mind with the time frame. It's a 12-month. Okay, I know we talked about the role of a dopamine that it plays with substance use disorder. We talked about a pleasure and reward system and all that, but I think it's important to talk about 2 other important neurotransmitters in the setting of alcohol, and that is GABA and glutamate. Normal physiology is that alcohol is a central nervous system depressant. It's going to slow down, right? Sedation and all that. So it works by stimulating GABA. Remember, GABA is our inhibitory neurotransmitter. It's going to inhibit, slow down. Think of this as like a brake paddles, right? Now, what happens is when you have too much alcohol, that's your acute intoxication, GABA will be too much. GABA is going to be produced in excess, right? Now, and that will cause further CNS depressant or sedation. Well, that makes sense. When you have a client with a chronic alcohol use, the balance of GABA, which is inhibitory, and glutamate, which is the opposite of GABA. Remember, glutamate is excitatory, right? So if GABA is your off switch, glutamate is going to be your on switch. It's excitatory. Now, so there has to be a balance, right? So what happens is a glutamate is overly produced to balance the effect of GABA. So if GABA is too much, and you know, because you know GABA is inhibitory, and then drinking is, or alcohol I should say, really causing GABA to be produced in excess. So then but we need to balance it out, right? So then you're going to have too much of glutamate in response to that. So what happened is when a client stops drinking, and you see alcohol withdrawal effect or syndrome. So when you have a client who has been drinking for long-term chronic drinking, stops drinking or decrease the amount of drinking, the GABA signal suddenly decrease, right? That makes sense because GABA was being increased under the influence of alcohol. So what will happen is it will result in overrepresentation of a glutamate. Remember, glutamate was also increasing to keep balance of these things. Now, the excess glutamate cause that autonomic nervous system, hyperactive state that we see in alcohol withdrawal syndrome. We're going to talk about intoxication and withdrawal management in a few minutes, okay? Right now I'm just setting a stage for the pathophysiology behind it. Okay, why are we talking about alcohol today? Well, because of some complications, right? So alcohol use disorder is the most prevalent of all substance use disorder, and over 5%, that's about 3 million deaths worldwide are due to alcohol every year. That's a huge number. Prohibiting alcohol in 1920 was unsuccessful at that time. However, deaths from liver cirrhosis were dropped, so that's interesting. A repeated intake of high doses of alcohol can affect pretty much all organ systems, especially your brain, your central nervous system, your peripheral nervous system, GI tract, cardiovascular, endocrine, and of course overall impact on psychosocial and so forth. Alcohol use disorder is significantly or will significantly increase the risk of accidents, violence, and suicide. Okay, talking about some more complications. We have fetal alcohol syndrome. This is where you have a client, a female client, who was drinking alcohol when she was pregnant, and then we see some birth defects. So look at the image here. You have a child with a small head circumference, epicanthic fold. Look at the philtrum. This is the area, right here from the nose to the upper lip. It's going to be smooth. You cannot appreciate that. You also have a small midface. Unfortunately, some behavioral issues, low IQ, and so forth. So take a look at this image. I think it's important, and we should intervene early on. And these are considered high risk pregnancy, and we should refer these individuals with a substance use disorder to a clinician who has special training and expertise treating these disorders in pregnancy. Okay, well, in early January 2025, we had Surgeon General's Advisory, which is a public statement that calls our attention to an urgent public health issues, talks about alcohol use as a leading preventable cause of cancer. Most people knew the impact of tobacco overall and risk with associated with cancer, but with alcohol, these findings were published, and it talks about different types of cancer, like oral cancer, pharynx, larynx, esophagus, breast cancer, liver, your colon and rectum, and so forth. And I think the takeaway message from here is that A, it's a leading cause, and number two, it's a preventable cause of cancer. Okay, I think we all know that all U.S. states have blood alcohol concentration as a legal limit for driving, and that's 0.08 gram per deciliter or 80 milligram per deciliter. Now, that doesn't mean that if somebody was driving and their blood alcohol concentration was less than 80, let's say 50 or 20 even, that they cannot be in trouble, especially if they had a poor outcome. They can be charged with impaired driving or driving under the influence, DUI, even below the legal limit per se. So I think people need to understand that, especially adolescent teenagers. Well, first of all, they should not be drinking, and especially not drinking and driving, especially today's day and age when we have access to cell phones and Uber. There's absolutely no reason why somebody need to drive when they are under the influence, if you will. But just to give you a visual, when we talk about 80 milligram, a standard drink is approximately, which is 10 to 12 gram of ethanol. It can raise the blood alcohol concentration by 20 milligram per deciliter. So if they got maybe 2, and that's a 40 right there, right? And it doesn't take that long to get to 80. On top of that, every person is different. Your metabolism, there's a genetic component, how we metabolize things, right? Like alcohol, your BMI, your gender, and there's so many factors. Were you on empty stomach? Were you eating something? The overall duration, was it drinking too fast? Over how many hours or minutes? I don't know. But anyways, the point I'm trying to make is, it's dangerous. It's not worth it. It requires a lot of education, especially I'm going back to your high school or child adolescent education, talking about like a primary preventions, if you will. I think it's very, very important. I understand this is a busy slide. I'll try my best to keep it simple. The topic is overall complications of a chronic use of alcohol, especially neuro complications. We have two things going on. Wernicke encephalopathy, which is acute, and because it's acute, it's going to be, if we intervene early on, we can reverse it. And then you have a chronic and irreversible type, and that's called Korsakoff syndrome. Now, because this is acute, the presentation is going to be more of like a delirium, ultramental status, and so forth, confusion. And with a chronic, you're going to see a presentation similar to dementia, your memory loss, and so forth. The cause for acute encephalopathy, Wernicke's encephalopathy, is untreated severe thiamine, or which is B12 deficiency, due to poor diet in the setting of alcohol use, chronic alcohol use. What happened is impairs thiamine absorption in the GI tract. So in other words, we have a thiamine in the GI, this is normal physiology, which will be absorbed, and you need a thiamine for a glucose metabolism. But alcohol is going to prevent or impair absorption of thiamine from the GI tract. And if you cannot absorb, then you're going to have a difficulty metabolizing glucose, and that's why you see these symptoms. Remember, glucose is important for our brain. Brain only needs two things, right? Glucose, simple sugar, right? And oxygen. Those are the two main things. If you do not feed our brain glucose and oxygen, that's considered acute insult to brain, and then you will see symptoms very quickly. All right, don't try that at home, by the way. Okay, then on the right hand side with the chronic side, you see symptoms because of alcohol and overall nutritional deficiency. When you have a client who's been drinking chronically for a long time, their intake is going to be poor, especially those nutritional intake, right? Your micro nutrients, if you will. So what's the treatment? Well, the first thing we do here is we start infusion of thiamine, usually through IV, even though you can give IM. But these patients are going to be in the acute setting, like in the ER, in the hospital, if you will. And then once you stabilize that, and then we give glucose. The reason you don't want to give glucose first is because you need thymine to metabolize glucose. If you just replace with the glucose and you don't have a thymine, you can't absorb it through GI tract, then how are you going to metabolize glucose? You'll just cause hyperglycemia at that time, right? So we give IV because we're going to bypass the GI tract here. So that's the treatment, and prognosis are excellent, especially if we intervene early on. That's why, you know, early intervention is important. However, on the right hand side, there's no treatment. It's a chronic. It's the damage has been done. It's a supportive care, and the prognosis are very poor. Okay, well, let's talk about the diagnostic criteria for alcohol use disorder. You know, before we do that, I do want to make a statement. I think I mentioned that earlier, but it's worth repeating that. Remember that all substance use disorders, they follow a same or similar set of diagnostic criteria. What do I mean by that? Well, the example that you have in front of you right now is for alcohol use, but it doesn't matter what type of substance use disorder they have. If they have a tobacco use or opioids or anything else, you simply replace that agent. Here it says alcohol, alcohol, alcohol. You replace that with opioids or tobacco or whatever the disorder you're dealing with, but the rest of the criteria does not change. The terminology is the same or similar, I should say, and also the diagnostic, the time frame and other criteria does not change either. It says at least 2 of the following, and there are 11 of them. You see 6 in front of you, and then 7 through 11 is on the next slide, and that does not change. So you need 2 out of 11, and you need that within the 12-month period. So that does not change either. So within a year, that's your look back period. That doesn't change, and the overall 2 out of 11 does not change. Now, because the criteria for all substance use disorder is the same or similar, I am not going to present that with the rest of the disorders. You can just use this as a template. What is different is, though, is your criteria for intoxication and withdrawal, and that I will present moving forward with the rest of the substance use disorders. Okay, so just remember that. Okay, so I'll spend like maybe like a minute or so on this. That way you know how to read this and how, you know what exactly they're talking about. So the first thing is you have a substance, in this case is alcohol, is often taken in large amounts or over a longer period than was intended. And then number 2 is there's a persistent desire or unsuccessful effort to cut down or control alcohol. So there's a behavioral component to it. A great deal of time is spent in activities necessary to obtain alcohol. In this case, is alcohol. If this was an opioid disorder, then you'll be opioid, or tobacco, you replace that, right? And there's a craving. There's overall impact on you, on your role and obligations at work, at home, or at school, or both. So please take a look at it. So again, take a look at 7 through 11. You know, there is a built of tolerance. We talk about that concept. Now you need to take more just to get the same effect, and withdrawal. We're going to talk about intoxication and withdrawal in a few minutes. And also, I think it's important to really specify if this client is in early remission or in sustained remission, and you can take a look at the criteria, and also specify if this is in a controlled environment. You know, for example, all of my clients, you know, I am in inpatient, right? That's where I practice. My clients are going to be in remission in a controlled environment. That means that they do not have access to alcohol, right? Okay, I think it's important to keep some differential diagnosis in mind, especially if you have some presentation but they're not meeting the entire criteria for alcohol use disorder. So we can say that it might be a case of a non-pathological use of alcohol. So therefore, drinking even on a daily basis in a low doses or occasional intoxication does not really make a case for substance use disorder, right? Remember, you have to go back 12 months and you meet the criteria that we talked about. Now, is it possible that the symptoms are due to something else, like sedative or hypnotic agents or some benzodiazepine, maybe something for anxiety, because the symptoms do kind of overlap. There's similar presentation where you have a sedation and so forth. So it's important to really find out the cause for those presentations. Okay, this is a very quick 4-question test which is used simply to screen a patient for presence of alcohol use disorder. It's a basic yes and no question, to be honest with you. I love this questionnaire. We call it CAGE questionnaire. C stands for have you ever felt you should cut down on your drinking? It's a yes or no question. A is for have people annoyed you by criticizing your drinking? That's usually a loved one's family member, right? Have you ever felt guilty about your drinking? That's G. And have you ever had a drink first thing in the morning? Eye opener. A total score of 0 or 1 suggests low risk of a problem drinking, and a score of 4 is pretty much a diagnostic for alcohol use disorder. So some other supporting diagnostic markers that we can do is some blood work like your liver function test. We know that both ALT and AST are liver enzymes that are increased when you have liver damage, any type of a liver insult. And in this case is because of alcohol, so you will see increased level of AST and ALT. But also remember that ALT is more specific to liver, and AST is found in some other organs as well, like heart or some muscle tissues. But the main thing to remember here is that AST is found in mitochondria, and alcohol actually damage our mitochondria. So when you have both AST and ALT level high, but more specifically when AST concentration or elevation is higher than the ratio is higher than the ALT, that really suggests us perhaps it's a mitochondrial damage due to alcohol. So something to keep in mind, the ratio for AST will be higher than ALT, but both of them will be damaged or higher. Another thing, the test that we can do is GGT. So that if that's elevator, that's you're building your case now. Another interesting test is a CDT. If that's elevator, you're really, especially in the combination of GGT and CDT, you're making your case. One interesting point here is that both AST and ALT levels are going to be elevated in chronic setting, and this really show you the overall chronic damage, right? It's not going to be elevated the next day or so. It takes a while for liver to really spit out those enzymes. However, your GGT and CDT, they once they're elevated, they can actually go back to normal, especially if the patient stopped drinking. So this really helps us. And if the levels are elevated, that tells you it's an acute issue, not a chronic, right? Because they go back to normal very, very quickly. So that cannot be chronic if they're elevated, right? So that helps us to see if the patient is actually following the protocol, if they are on a treatment. And if the goal was to actually stop drinking altogether, this will be a good test, because it actually has a good sensitivity, especially if they're done together. Some other criteria, like again, supportive evidence. When you look at the CBC, if their MCV is higher than normal. So that tells you it's a macrocytic. So if this is the normal size, normocytic, and this is going to be micro, the size of the RBC is small, and then if it's a macro, then it's huge. So remember, you need B12 and folic acid to mature these cells. Macro, if its size is big, that doesn't mean it's a good thing, right? So you need to get it mature and then make it more denser. So if this is normal and the size is when you do the blood test, if all you see is a lot of macrocytic anemia, if you will, that tells you perhaps that there's a nutritional deficiency, if you will, your B12, thiamine, and folic acid, and so forth. So again, this is more of a supportive evidence. It can help if the patient is drinking alcohol or not. But since the half-life of these blood cells are, they have a long half-life, like in 90 days or so, it really doesn't, you don't see a quick change. So it's not going to help you to determine if they have stopped drinking or not. Let's see, another supporting evidence may come from elevation of some other blood work, such as maybe their lipids, their triglycerides are going to be high, their overall cholesterol, or maybe their uric acid is high. So this is all like a supporting evidence, and that tells you the overall impact of alcohol in the body, right? Okay, now let's talk about the treatment approach for alcohol use disorder, and especially if the goal is abstinence. Now, the first agent on the list is our drug called disulfiram, and the brand name is Antabuse. The way it works is that we have an enzyme called acetaldehyde dehydrogenase. It's an enzyme because it ends with ase. This enzyme is needed to metabolize alcohol, but this drug will actually inhibit that enzyme. So if you're inhibiting an enzyme that will metabolize alcohol, what will happen to the concentration of alcohol in the system? Well, it will start to build up, and that will actually result in side effects, severe symptoms such as nausea, vomiting, headache, and difficulty breathing, and so forth. So it pretty much discourage you from drinking alcohol because you do not feel good. Now, before we start this patient, these individuals on this medication, make sure they are not drinking alcohol at all. They need to be alcohol free. Otherwise, if they have alcohol in their system and you give a drug that's going to stop their alcohol metabolism, that will cause the symptoms, and that's not nice, right? On top of that, I think patient teaching should be that they cannot take, when they're taking this medication, they cannot take anything. They cannot drink alcohol, but they cannot take any agent, even if it's over the counter, that may have alcohol in it. For example, mouthwash that may have alcohol. What else? Gosh, shaving lotion, or anything that may have some over-the-counter, maybe cough medications that may have a small amount of alcohol. So be very, very careful because they can have a severe side effect. Remember, they do not have the ability to metabolize alcohol because we inhibited their enzyme. Here's the dosage in front of you, and I don't need to go over. You can take a look at it, and the most important thing is keep an eye on their liver enzyme because of a hepatotoxicity. It's usually not used as a monotherapy. It's you can have another agent, or maybe like a psychotherapy, and those options that we talked about in our part 1. There is a little ethical dilemma, when you start somebody on a medication for alcohol use, and if you know that they don't have a control over it, and they're going to crave and they're going to drink alcohol, you're giving them a medication where if they end up drinking alcohol, they won't be able to metabolize and they will have a side effect. then they can actually get seriously sick, or they can aspirate, right? They can get aspiration pneumonia. They can die because of these other issues that was caused by the drug. So you can see that ethical dilemma, that how is that a good thing, right? So remember, treatment, in generally speaking, for anything in general, treatment cannot be deadly or dangerous than the disease itself, right? Solution cannot be more problematic than the problem itself. So we have to keep that in mind. So therefore, usually this is not a first line treatment. You do not see that a lot, but it's a good treatment if the patient understand that I will not drink, and they understand and they're willing to take this medication. Now, another drug that works very well is actually naltrexone. This medication will block mu opioid receptor and also modify your hypothalamic pituitary adrenal axis to suppress the alcohol consumption. So the idea behind is that we're going to start with the reduction of the amount of alcohol that you use, because you're not getting the effect out of this, right? May start a treatment when the client is still drinking, so it doesn't need a complete commitment to stop drinking first, which is different from the anti-abuse drug that we just talked about, right? And here are the dosage in front of you. You can take a look at it. Side effect of this medication is nausea, your GI stuff, decreased appetite, abdominal pain. Again, monitor liver enzymes, just like we talked about the first drug. So you have to be very careful if the patient already has liver disease, and there's a contraindication if the patient is using opioids for pain management. Remember, it's going to actually block your opioid receptor. These are the same receptors for pain, right? So if you are going to use naltrexone, make sure patient is not in pain or they're not taking pain medication. Otherwise, this drug will actually reverse the effect of pain medication. That pain medication is not gonna be effective. So you have to be very, very careful. Make sure the patient cannot use opioids, needless to say. So what if the patient is scheduled to have a surgery, and you anticipate that they need to be on a pain medication? Then we need to stop naltrexone at least at that time. Otherwise, those narcotics will not be effective. So that's something to keep in mind. Okay, another agent is acamprosate, or Campril is the brand name. Very interesting mechanism of action. It's actually going to modulate glutamate neurotransmitter, causing anti-drinking neurochemical effect. It simply means when we talk about to modulate any neurotransmitter, modulate simply means it's not going to increase the effect or decrease the effect. It's going to actually bring it back to its normal state, if you will, right? Their natural response, whatever they were supposed to do. Remember, we talked about the pathophysiology of alcohol, where I said when you keep drinking, your level of GABA are increased because you're getting sedation, right? It's a depressant, and GABA is causing sedation. That's your brake pedals. And then also I said the chronic response would be that I need to increase glutamate somehow to balance things out. Remember, it needs to be balanced on any given day. So then you have increased level of glutamate. Now, this medication will actually modulate a glutamate level. Actually, it does modulate GABA as well, to be honest with you. Pretty much what it's doing is bringing back these neurotransmitters to its neutral state. We make sure that the patient is not drinking alcohol. There needs to be in abstinence state first, and then we introduce this medication, and then I call this as like a fake alcohol, if you will, right? It's gonna give you a similar type of feeling. It's not gonna cause high or sedation or anything like that, by the way. It's gonna just prevent drinking because you're getting the effect from these neurotransmitters. Okay, so it's considered as a maintenance drug. Dose is pretty interesting, actually easy to remember. It's a 666 3 times a day. Or if you have a significant renal function, then you decrease the dosage by half. So 3 times a day, easy to remember. The one interesting thing about this drug that wasn't the case with the first two agents that we talked about is that this agent is safer in liver disease. Remember, with the first two we talked about check their liver function, and if there's a liver damage, we need to be very, very careful. In this case, it's safer in liver, but in this case we are going to be worried about kidney function. So if there's a kidney damage, then this is not a good agent. And here are some side effects from this agent. Okay, next agent is your topiramate, which is Topamax. That's a brand name. Remember, this is your seizure medication, right? So the mechanism of action is it's going to actually block your voltage dependent sodium channel. So if this is your cell, and remember, when sodium enters, sodium is considered, like excitatory, if you will, right? So sodium enters, and we need to actually block that. If you block, you're causing some calmness, if you will. Remember, that's how we treat seizures, tremors, and anxiety, and so forth. So you're going to increase your GABA effect and decrease glutamate. Remember, glutamate was your excitatory and GABA is your inhibitory. All right, so this medication, it's not a first line, by the way, but if the patient cannot tolerate some other drugs, this is a good medication. Or maybe patient has some history of seizures and maybe headaches and so forth, so this might be a good adjunct medication. Here's the medication dosage in front of you. Some side effect, your GI side effect, abdominal pain, nausea, vomiting, diarrhea. There's some weight loss. I know some people use that part of their weight loss program. So anyways, keep an eye on the renal function. Because this is your anti-epileptic medication, there is risk for your cleft palate defect, right? So very, very important. If you have a female client planning to get pregnant or is pregnant, then this is not a good medication for that client. Some other second line treatment, I'm not going to spend too much time on this, is your gabapentin, Neurontin. Again, it helps with to calm down your nerves. It's very weak anti-seizure medication, but we use that for like a peripheral neuropathy and so forth. Baclofen is another agent. Again, these are your second line. This is not a first line treatment. Some other agents, I wouldn't even call them as a second line. We have unclear efficacy. Some people do use that. Ketamine is one of the options. Your GLP-1, agonist medication, like Ozempic, your Zofran, and Prazosin, and doxycycline. These are some options for some patients, especially if they are not able to tolerate the first line agents that we talked about. Some non-pharmacological interventions, we have already talked about those. This is just a recap. CBT, your motivational interview, counseling, group therapy. We know the role of AA, Codependence Anonymous Group. Remember, I gave you those examples in part 1, so please take a look at that. Here is a very simple summary of our 12 steps program, if you will, for Alcohol Anonymous Group. Take a look at it. One thing we know is that this program was designed with keeping faith in mind. That was the whole point. And this program is actually widely used in pretty much all communities across the planet, if you will. And some people have modified this to make it more secular, and that's fine. If you have a client who does not believe in God or doesn't share the same faith values, if you will, the end point is to really to make changes in your life, and it doesn't matter how they do it. So options are available. So make sure you identify that barrier, if you will, and offer them that secular 12-step program. Okay, so what I did for you is I actually created a treatment summary table for you, and you will see that at the end of each substance use disorder. I think it's a nice summary, especially if you just want to do a quick review right before the exam. For each table, you will see the main receptors that substance is focused on. For example, in this case is your GABA and glutamate, and addiction strength, if it's a high, low, moderate, and so forth. And then how do you treat, if outpatient is preferred versus inpatient. We do inpatient, especially if you're dealing with a severe withdrawal. We're going to talk about that in a minute. And then in the middle, you will see psychotherapy options like a CBT, motivational interview, and 12 steps. And then on the right hand side, you'll see a pharmacological interventions, first line naltrexone and either oral or extended release, injections and so forth, and then some second line treatments. So again, a quick summary of treatment options. Okay, so far we talked about alcohol use disorder and how to diagnose and how to treat. Now we're going to talk about alcohol intoxication. What do you do when you have a client in front of you going through intoxication? And that simply means they drink too much. They ingested too much alcohol, right? And here's a diagnostic criteria. I'm not going to go in depth at all. You can take a look at it. You need one or more of the following, and then you know what presentations are for alcohol intoxication. You have seen those individuals before, right? Or maybe you have personally experienced that. I don't know, unsteady gait, slurred speech, incoordination, and so forth. Okay. Again, I'm not gonna read these slides. You're more than welcome to go through these. They're very simple, basic information. Okay, but I will focus on the treatment. A primary goal for a client who's going through alcohol intoxication is to support them until they metabolize alcohol, right? Most of the time, not always, they're going to be in inpatient, maybe in the ER and so forth. So ABC, assess their breathing, airway, breathing, circulation. Make sure you stabilize them. Keep an eye on their vital signs and do IV hydration. We talked about a role of thiamine to prevent complication like a Wernicke's encephalopathy, and glucose. Give them maybe IV or PO, depending on how critical the patient is and severity of those symptoms. Of course, you might have to replace their electrolytes, especially magnesium and potassium and so forth. And there's no one treatment. It really depends on what's going on with the patient. You assess and you stabilize them. Now we're going to talk about withdrawal diagnostic criteria. Remember, for every substance use disorder, we have three things going on. You have a substance use disorder criteria, then you have intoxication criteria, and then you have a withdrawal criteria, right? And intoxication and withdrawal are opposite to each other. With withdrawal, at one point they were drinking too much alcohol for a long time period, and now they are not drinking, or they're not drinking enough. There's a decrease. So all of a sudden you see symptoms that comes from, remember, your increased level of glutamate, right? So because glutamate is excitatory, you will see autonomic hyperactivity, sweating, tachycardia, tremors, insomnia, nausea, vomiting, some hallucinations, either visual, tactile, auditory, and so forth, psychomotor agitation, anxiety, and your generalized tonic-clonic seizures. Remember, tremor, seizure, anxiety, they do share a similar presentation. All right, and you need 2 or more of the following, which is 8 altogether. So you need at least 2. Most of the time, your patients are going to have more than 2, by the way. But you only need 2. All right. When do you anticipate these symptoms? It really depends on what textbook you're using. By the way, I've seen 4 to 12, I've seen 6 to 18, within 24 hours, and so forth. But you got the point, though, within a day, right? A couple of hours after your last drink, and within 12 hours or so, right? And we already talked about those symptoms. If we do not intervene, then they are at risk of something that we used to call delirium tremens, and now the new term is alcohol withdrawal delirium. And this is where they can have seizures, hallucinations. They see spiders or other insects, either bugs crawling on them. It's rare but very dramatic. It can be life-threatening, and that usually happens within 24 hours to 72 hours after the last drink. I think it's important to rule out some other causes of these hallucinations and some other symptoms, especially if they're in the ER. Do not automatically blame on the alcohol. You can have underlying issue like a GI bleed, hypoglycemia, infections, head injury, electrolyte imbalance. So it's important to really assess appropriately and treat and manage those symptoms before we really think it's alcohol withdrawal. You can have both, right? You can have hemoglobin of 4 or blood glucose of 45 and alcohol withdrawal at the same time, right? So very, very important to assess our patient literally head to toe. One of the commonly used assessment tool is something that we call CIVA. It's a Clinical Institute of Withdrawal Assessment for Alcohol. There's a revised revision scale, and the purpose is to really quantify withdrawal severity and help us to initiate treatment, and that's usually benzodiazepine, and how much do we give. And that's the purpose of using the scale, and this is used during withdrawal management, not during intoxication. I think that's important to understand. Okay, so this is a withdrawal. It's in the name, actually. All right, so let's talk about this. Okay, well, CIVA actually has 10 items altogether, and this is how you score them. 0 to 9 is mild. You just monitor them. Usually we do not start a treatment here. 10 to 19 is a moderate. This is where usually we start a benzodiazepine, and any number above 20 is severe. That requires aggressive treatment, possible ICU. The max score is a 67, and then we assess every 1 to 2 hours in the beginning, and then as needed. You will be doing this as a homework assignment. This slide is really a summary of everything we talked about regarding alcohol withdrawal. The time, 4 to 12 hours, and so forth. The symptoms, we talked about those. Prevent seizures, DDs, your CIVA scale, standard protocol follow, when to initiate a benzodiazepine, that's the first line. Thiamine, some other supportive medication like a folic acid and multivitamins, IV fluids, plus minus electrolyte balance if needed. Depending on tachycardia, we can introduce beta blocker or clonidine if they have severe hallucinations. Plus minus antipsychotic medication. Usually in the ER, we use Haldol, but again, we have to be very, very careful because every medication has a side effect, of course, right? Keep an eye on this slide. I think this is a good summary on how to treat a client with alcohol withdrawal. All right, well, we're officially done with alcohol use disorder. I know I spent a lot of time on that, but that was important. Remember, alcohol was your number one and the most commonly used psychoactive substance. Number 2 right now is a caffeine. This is the second most commonly used agent. You're more than welcome to take a break or grab a cup of coffee, if you will. But let's talk about caffeine now. Okay, so what is the physiology behind it? What are the main receptors involved with caffeine and its effect on the body? Well, the main thing is going to be really adenosine receptors. What happens is adenosine promotes sleepiness and suppresses arousal. And that's a good thing when it's time to go to bed, right, at nighttime. However, if you want to be alert, you actually want to block the effect of adenosine, and that's what caffeine does. It actually acts as an antagonist at these receptors. So caffeine will block adenosine, and that will lead to feeling more alert and more awake, if you will, right? And then also caffeine can increase a level of adrenaline and cortisol. Now there's an indirect effect, so this is more of like a direct effect on how it can make you more active. But behind the scene, what happens is when you block adenosine receptors, you're indirectly increasing dopamine signal in the brain. This signal is not as strong as nicotine, but it's strong enough to form some kind of like a mild habit. And ask anybody who's addicted to morning coffee or tea, they'll tell you that yes, you can feel that effect if you don't get caffeine. So this is your normal physiology. Okay, remember, caffeine is not just in our coffee, right? And there's some other drinks that may have caffeine in it. So how much caffeine is present in a drink? It really depends on type of drink. For example, 1 cup of your regular instant coffee may have 60 milligram of caffeine. Okay, remember one big number here. If the amount is more than 250 or reaching about 250 milligram, then that may cause some intoxication effect, and we're going to talk about intoxication in a minute. So just remember, big number, 250. So if 60 milligram, 1 cup, that's not too bad, right? It depends on how many cups you're using in a day, right? Or taking in a day. Cappuccino, 100 milligram, long black coffee, 200. We're getting better and better now, right? Right there. If you got two long black cups of coffee back to back, gosh, that's a 400 right there, right? Red Bull, 80 milligram, green tea, 30 milligram. Okay, seems like that's the safest option here. Look at a Monster, as name applies, 160 milligrams, and if you got 2 of those and so forth, right? Coca-Cola also has about 50 milligram or so. So keep that in mind, how many cups or drinks you're having in a day. Okay, there's no criteria for caffeine use disorder, by the way. This is the only exception. Every other substance use disorder will have that criteria, which is similar to alcohol use disorder, and I'm not going to cover those anyways. But for caffeine, we'll talk about caffeine intoxication, and then we'll talk about caffeine withdrawal. Okay, for this, as I mentioned, typically a high dose above 250 milligram, and you need 5 or more of the following. There are 12 altogether. So if you have 5 out of 12, if you take too much caffeine, what happens? You're feeling very restless, right? Nervous, insomnia, can't go to bed, and so forth, right? So take a look at it. It's easy to remember, and that's all it is. Okay, so next is caffeine withdrawal criteria. This is going to be the opposite of intoxication, of course. Prolonged daily use of caffeine, and now all of a sudden they don't have that in the system, or it's a decreased amount. That usually happens if they're traveling or they have no access, to coffee or something like that. Within 24 hours, they will have 3 or more of the following symptoms. There are 5 altogether, so you need a 3 out of 5. And number 1 symptoms people complain, report is, I'm sure you agree with me, is a headache. Gosh, my head hurts. I think it's time for me to drink coffee, right? That's your withdrawal effect. Or they're feeling tired, or drowsy, or maybe can't concentrate, and so forth. Anyways, take a look at this criteria. I think it's pretty easy, right? Okay, here's just a summary table for treatment for caffeine use disorder. Please take a look at it. All right, well, now we have number 3, cannabis use disorder. Take a look at the definition. It's going to be very, very similar to what we saw under alcohol use disorder. Another name for cannabis is marijuana. Some people call it a pot or weed. It does come in a different flavors, if you will. It can be smoked, vaped, topical, or eaten. For some clients, it results in euphoria and maybe a memory impairment in others, and depending on what type. Our brain, our body does have a natural marijuana. We call that anandamide. What happened is that we do have receptors. Cannabis actually bind at these two receptors, CB1 and CB2. There are many different mixtures of cannabis, maybe over 100 of them. Two most important mixtures of cannabis is a CBD and THC. The THC concentration is commonly used as a measure of a cannabis potency. So what happened is, if we're going to talk about a pure CBD, pure or higher concentration CBD, that will have anticonvulsant properties, antipsychotic or anti-anxiolytic, so it's going to calm you down, anti-anxiety type of properties, anti-inflammatory properties, antioxidant, and so forth, and a lower risk of psychosis or memory impairment. That's a pure form of a CBD. Okay, now with THC, if that's a pure or high, that is a relaxant. You feel very friendly, slower thought process, appetite stimulant, may help with some pain management, analgesic property, euphoria, and high dose can give you some drowsiness, psychosis, and panic attacks. So that's your high dosage of THC. Now, remember I said THC concentration is the measurement of how potent that cannabis is. More potent cannabis means you have a high THC and less CBD. And so the problem is you have less CBD, and pure CBD is the one that was giving you the help with anticonvulsant or anti-anxiety and so forth. So the issue with medical use is that we don't know the overall concentration, and there's so many variation between one plant to another. It's very difficult to create a standardized product, if you will, to really treat one symptom, and that's a big problem with this plant, if you will. Generally speaking, there are 3 primary species of cannabis plant. THC that come from cannabis sativa is uplifting and energetic. THC that comes from cannabis indica is more relaxing and calming, and THC that comes from ruralis may increase appetite, but is rarely used for recreational purposes. Here is a list of some common cannabis intoxication symptoms. Just take a look at that, please. You may have some mild symptoms such as maybe dry mouth and red eye. Euphoria is very common, especially in the beginning at least. But then you can have some serious side effect as well, like a tachycardia, impaired judgment, and impaired motor coordination. And here's a list of cannabis withdrawal symptoms. Please take a look at it. It's going to be the opposite of what we talked about, right? So now you're going to see decreased appetite, depressed mood, restlessness, right? You no longer feel happy, you're good, right? So that euphoria is gone. And the cycle continues. That's the whole point here, right? You're going through withdrawal, you're looking for access again, and then it continues. And here is a summary, a treatment summary for cannabis use disorder that you can take a look at it. Okay, number 4 is hallucinogen related disorders. Take a look at the definition, which is going to look very similar to alcohol use disorders. There are many different types of hallucinogen. I'm not going to spend too much time on this topic at all, but there are some that's very potent, like a PCP or angel dust, people call, and some other less potent agents like a ketamine and some other medications. Overall, they act on your NMDA receptor antagonist. Remember, this is where you have your increased level of a glutamate, so you're going to act as antagonists. You're going to calm them down, and that's where you get the feeling of dissociation and then anesthesia. We talked about a ketamine in antidepressant lecture. Okay, so please take a look at it. I'm not going to spend too much time on this. Here are some other hallucinogen in front of you. These are the examples, and here are some signs and symptoms of these agents. Hallucinogens do not have withdrawal symptoms. So here's your treatment summary for hallucinogen use disorders. Okay, number 5 is inhalants use disorder. Take a look at the definition, please. So here's a list of different types of inhalants. These are very cheap products that unfortunately a child or adolescent they tend to use this. They get together in the backyard or garage and stuff like that. That's usually their first agent to try. And so that requires a very good parent education, again going back to primary prevention in high school, elementary school, and so forth. An example includes some toxic gases, from glues or fuels, paints, and so forth. Freon, if they are using that, it can really freeze their lungs. And the sad part is, if they are most of these gases, they are not going to be detected on blood test. So here are the some symptoms from these agents. Here's just a visual in front of you. Please understand, even though these agents are so cheap, but they have potential to cause brain damage and some serious side effect, risk of damaging your kidney, liver, and some other organs. These are heavy metals, so it requires a lot of education. Just because some of them are over the counter, most of them are, that doesn't mean they are risk free. And inhalants also do not have any specific withdrawal syndrome. So here is the treatment summary for this disorder. Okay, well, I think it's time to take a bio break. We covered 1 through 5. I'll see you back in part 3. We'll finish rest of the substance use disorders. Okay.